So it's just fractured, not a break. Hello and welcome to this week's Urgent Bite, brought to you by the Royal New Zealand College of Urgent Care. My name is Guy Melrose, and today I'm sharing my thoughts again on the language of medicine. As I said a few weeks ago on the podcast about eponyms, the language of medicine has always fascinated me. In the case of eponyms and word derivations, I find it helps me understand more and retain information about certain topics and conditions. But in medicine, we use language to extract information from our patients, inform our patients, and also communicate with our colleagues. We use verbal and non-verbal communication, and medicine has the age-old practice of writing notes to communicate with a future colleague or future self. Language is such a major part of medicine. Now, I got thinking about this having read a recent post that our Director of Clinical Training, Dr. David Sorrell, put on our Facebook page earlier this week. And he linked to an article about medical jousting. Now, I highly recommend you read this, as it talks about the act of uninformed criticism of a colleague. And it mentions comments that can be made to a patient that explicitly or implicitly criticises a previous doctor's work or opinions. Now, when I reflect on this phenomenon, I think the language we use plays a big part in how this can occur. Not just the doctor who is being critical, but also the language the previous doctor used. It could be how they explained the diagnosis to the patient. So the patient has perhaps misunderstood what the doctor had told them and is now relaying a misrepresentation of the consultation to the current clinician. Or it could be that the referral, either written or verbal, misrepresented things such that the current clinician has got the wrong end of the stick. Now, I'm sure you've all had incidences of patients misunderstanding what you've told them. For example, I've heard a patient phone a relative as I left the room to say that they are relieved they have not broken their arm, they've just fractured it. It's difficult to know how much a patient has understood about a possibly very complex situation, and in urgent care we only have a very limited time to take a history, examine, diagnose and explain our treatment. This time constraint may cause us to rush, and rushing may cause us to talk too fast or make assumptions about patient understanding. And the issue of whether a patient has understood is complex. Now, I consider myself as having a certain level of intelligence, yet if you put me in front of an accountant or an economist talking about taxation, well, I might as well be listening to Klingon. They might think, oh, he's a doctor, he'll understand this. But it is so hard for me to follow, I have to constantly get them to slow down and go over things again. So if I rattle off to a patient the definition of asthma and how we treat it, even Elon Musk might ask me to slow down a little bit. And what if this conversation involves practice-changing information? So if a parent is expecting an antibiotic for a condition, and you're explaining why their child does not need it, can we expect them to understand and assimilate this information straight away? When you learn new information at a conference, it takes time to fully reflect and process the information, yet we expect patients to understand and comply straight away. And this machine gun approach to sharing information applies to when we call a specialist for advice or referrals. A stressed registrar on a crackly line in a busy ward trying to listen to a stream of information must be very difficult. It is no wonder they might miss some important details about your call or why you have concerns, and particularly if you include a lot of information out of order, rapidly spoken at the very start of your conversation. So when they then get to review the patient, they might think, why the hell has this been sent to me? And if our referral letter is very busy or is full of acronyms that they might not understand or are not used by everybody, or maybe is missing a really important bit of detail, you can see how the medical jousting phenomenon has now been set up to occur. Communication skills are taught throughout medical school, and there are many courses and books on the topic, and in fact it is a huge topic and something we do need to think about carefully. In urgent care, how can we maintain efficient speed but maintain quality communication with our patients and our colleagues? Well, I'd be interested to hear if you have any tips or tricks, but personally these are some of the things that I try and do, and I find that they help me at least. I really like using analogies when explaining things to patients. I find that in most cases, relating their condition to something relatable to them helps in their understanding. This is often a dynamic thing, often made up on the spot, but I do have some regular ones that I use. I like to refer to a custard cream biscuit when discussing the growth plates of children, for example. Now, I find that handouts are an essential part of the consultation. The take-home information for later consideration and sharing with family is so important and is an incredibly powerful tool. I also find it is a useful thing to give in the clinic prior to going to write your notes or script, so the patient can read it and ask questions when they return. These days I will often give people the website link rather than a piece of paper, as most prefer to look at it on their phones, but some advice pages also have embedded videos which are very useful. But it's obviously important to always check the information you are referring the patient to ensure it's accurate and up to date. Leading on from that, asking the patient if they understand what you have said and if they have any questions is, I feel, a very important end to the consultation and will easily highlight if they are having issues comprehending what you've said. It is important to ask and give them a second or two to think. I always try and think of myself sitting in front of the accountant getting that very same question, and how my brain is trying to spin up the disk, think through all the information and then formulate a question. Rushing at that moment would not help me, so our patients deserve a little time to contemplate as well. And then when calling the hospital, I like to use the handover tool ISBAR, which I've covered in a previous podcast, as it helps me to structure a focused start to the referral so the person on the other end of the phone knows the situation without listening to a lot of waffle. These handover tools are very useful, and finding one that works for you is well worth doing. But there are many tips and tricks, and I'm sure you all have your own ways of navigating this potential minefield. From an urgent care point of view, as I've mentioned before, the time constraints can push us to rush. We will often think about missing a diagnosis because of rushing, but failing to adequately explain a condition to a patient or include the correct information in a referral can also lead to problems down the line, so taking time to get it right is worth it in the long term and will ultimately save time. So check out the post on Facebook and the article that Dave linked to on medical jousting. And do please let us know via podcast@rnzcuc.org.nz what your tricks and tips are for getting an efficient transfer of information between you and your patient and you and your colleagues. Also, let us know your experiences of medical jousting. Now, we'll be back again next week with another podcast. I look forward to seeing you all then, but for now, thanks for listening.